Ladies and gentlemen, please welcome to the stage Dr. Stephen Kemble.
Thank you all very much. Okay, the title of this talk is Administrative Simplification. Let's let doctors be doctors again. The big problems in U.S. healthcare are primarily cost and access. And the dominant thinking in health policy is that we must reduce costs, so that means the price we must pay is to restrict access to try to bring the cost of healthcare down. Right? But there are some serious problems with this line of thinking. First of all, restricting access does not restrict disease, which generally pops up in other more uncontrolled forms in emergency room and hospitalizations and complications of chronic diseases. And second of all, when you start trying to restrict access or benefits or eligibility or those kind of things, all that requires bureaucracy, which ends up costing more than it saves from reduced care. So we have a very dysfunctional solution to our healthcare problems. The Affordable Care Act attributes excess costs in our system to too much care, and it blames fee-for-service causing excessive volume of services. And therefore, the idea is let's restrict services with managed care, formulary restrictions, and financial incentives for doctors and hospitals to deliver less care. Examples of this are value-based payment, shifting insurance risk to the providers of care, with capitation, bundled payments, shared savings, those kind of things, which push insurance risk onto the provider. So if you deliver too much care, you make less money, and if you restrict care, you can make more money. This is in conflict with our traditional ethical obligation to the best interest of the patient. So there's an element of pay for performance, which is supposed to assure quality so that doctors don't follow the financial incentive to restrict care inappropriately. There's also a big component of the Affordable Care Act of shifting more and more of the cost of care onto the patient in the form of higher deductibles and copays. This is much worse on the mainland than in Hawaii because we've been blessed with our Prepaid Health Care Act, which has buffered us from some of the worst abuses that go on in the mainland. But a lot of people now all over the country have plans with $6,000 deductible. So you're paying the premium every month, but if you get sick, it's all out of pocket anyway, so why did you pay the premium? You know, it's sort of a cruel joke. A colleague called the coverage in the Affordable Care Act like a hospital gown. It looks like it covers you in the front, but it's pretty skimpy in the back. In this country, we already rely heavily on incentives to restrict and deliver less care. And we already rely heavily on pushing more costs onto the patients. Our U.S. patients have more skin in the game by far than any other country. If these strategies work to control healthcare costs, we would not be spending twice as much as every other industrialized country on healthcare. I'd like to talk a little about pay for performance. Again, the idea is, okay, let's get detailed metrics on the details of healthcare, define protocols for best practices, and reward doctors for following those protocols, and sometimes financial penalties for not following them. This assumes that doctors are not motivated to provide good care and they need some financial prods in order to do the best job for their patient. There are two basic categories of motivation. And this is based on the psychology of motivation and behavioral economics, there's a lot of research on this. One is intrinsic motivation, which is the desire to do a good job, to help people, professional ethics, things like that. The intellectual challenge of medicine, the inherent satisfaction in the job. The other is extrinsic motivation, which is basically money or carrots and sticks, where you're trying to reward one behavior and not another. What behavioral economics shows is that this kind of strategy to improve the outcomes of a product works okay if you're having people that are manufacturing widgets where the procedure is the same for every case, and it's boring and people wouldn't do it on their own, so they need a financial incentive to do it. But if you apply it to something complex like healthcare, that requires a lot of individual variation, a lot of exceptions, there's a lot of complications, then it's absolutely toxic to improving care. You end up having measures that are not very valid, that again require a lot of exceptions, and the effort to meet those metrics is at the expense of other aspects of care that can't be easily measured. It leads to increased gaming of documentation, it leads to greedy behavior, it leads to focusing on money at the expense of patients, it undermines professional ethics. Don Berwick is the author of the Triple Aims, which are the supposed goals of healthcare reform, which is improved quality of care, improved population health, and reduced costs. And he himself called pay-for-performance toxic. There are studies that show that if you look at a typical primary care practice, about 25% of patients are complex. They have more than one interacting condition, they have psychosocial complications, they have difficulty paying for their medications. There's some kind of reason why they're not straightforward. If you look at the studies that were used to develop the protocols, they select only patients that are typical examples of the disease being studied, and they weed out everyone with complications. But those of us in practice are dealing with the complications a large percentage of the time. If you try to manage this from a bureaucracy, you either need a lot of people to deal with all the exceptions, which is very expensive, or you're going to be sacrificing all those exceptions because you're only going to reward the standardized protocol and you're not going to deal with the exceptions. Either way, it damages quality of care. Quality scores from pay-for-performance generally tell you much more about the patient population and the patient characteristics than about your efforts. They compared doctors who were graduates of Harvard Medical School, and the ones that were top scoring compared to the ones who were bottom scoring. And the bottom scoring ones had far more poor people, people who spoke languages, primary languages other than English, who had psychosocial problems. And that was the primary determinant of the lower scores, not the doctor's quality or effort. In large studies of many hospitals, 252 hospitals, they looked at the effects of pay-for-performance on health outcomes and found a slightly negative effect and absolutely no benefit. There are large meta-analyses of looking across all the studies that have been done on pay-for-performance that the conclusion is there's no net benefit for either quality of care or population health. So if P4P is official policy under the Affordable Care Act and it's being widely adopted by private payers as well as by Medicare, and there are no randomized control studies showing that it works, there's no improvement in the largest demonstration projects in population health. So we're implementing everywhere policies that have been proven nowhere, and this risks failure on a colossal scale. If you look at the results of first managed care and now ACOs and pay-for-performance so far, since 1970s, the number of physicians in this country has about doubled. The number of administrators has increased 30-fold. There are now far more administrators than there are physicians. Hospital administrative costs in the US are double those of other countries. The cost per hospital is something like $600 per month more in the US than it is in Canada. Physician billing and office expenses are about 4 times in this country what they are in countries with universal systems, and our overall costs are about 4 to 6 times what they are in other countries. In the large Medicare ACO demonstration projects, the pioneer programs that had the most risk and they're supposed to be the most advanced in implementing ACOs and pay-for-performance, they saved about 0.5% in Medicare payments for health care. However, and this information was not easy to get from the studies that were published, they spent about 1.5 to 2% on administrative costs and bonuses in order to get those savings, so it was a net loss of 1.5%. Very few primary care doctors have enough patients for statistically valid quality measures for most conditions. Multi-payer certified medical homes using, trying to achieve the PCMH criteria with meaningful use of electronic records. The ones that got farthest in that failed to show any improvement in quality or cost. 2/3 of ACO patients get some of their specialty care outside the ACO, so how can the ACO even manage that? Most ACO incentive payments go to free riders, doctors who are already practicing cost effectively, so the bonuses are given to them for things they were doing already. So that's just additional money for no benefit, and that outweighs any possible savings from reining in unnecessary care in the outliers. There was a recent study comparing small 1 and 2 physician practices with large practices of 3 to 10 or 11 plus doctors, and they found that the smallest practices had 30% fewer preventable admissions than the large practices did. And the small practices had a lower level of medical records, a lower level of PCMH certification criteria, and yet they outperformed the larger practices in keeping people out of the hospital by a wide margin. The bottom line is, if you have a doctor that knows their patients, they'll do a better job of taking care of them than going to a large system where they have more protocols and systems and things like that, but they don't know the patients as well. Hospitals, okay, let me come back to something else. Oh yeah, there's another study that looked at vertical integration, comparing large integrated healthcare systems which are supposed to provide improved coordination of care. They all drove costs up, not down. Physicians spend about 1/6 of their time on administrative tasks that are not essential to patient care in this country, far higher than any other country. So let's now pivot to what I think are the solutions. And let's start with an example of what they did in Western Colorado, in Rocky Mountain Health Plans. Rocky Mountain Health Plans has about 70% market share, similar to HMSA. They offer commercial insurance, they have the contract for all of Medicaid for Mesa County, Colorado, and they have a Medicare Advantage plan. They pool the funding from all those sources, and they pay their doctors the same regardless of where the money came from for an individual patient. So the Medicaid patient, the commercial patient, the Medicare patient are all the same as far as the doctor is concerned. They also have made some efforts to plan for the community in terms of resources, so they don't have too many hospitals or too many MRI machines. They try to keep it in balance with the size of the community. And they have a quality improvement program that's driven by the physicians and is not dependent on pay for performance. They have less than half the acute care Medicaid costs of the rest of Colorado, which shows you that if you can provide adequate access to outpatient care for Medicaid patients, you can really bring down the total costs for ER and hospital use. My idea on physician pay is, granted, we have perverse incentives in our fee-for-service system, but instead of eliminating those perverse incentives, we are adding equally perverse counter-incentives and creating a bureaucratic nightmare in the process. We need to make physician payment as incentive neutral as possible. And I can think of 3 ways to do this. The first is to put doctors on salary, as they do at the VA or Kaiser, which is incentive neutral. Whether you're doing a procedure or doing counseling or doing a physical exam, you're paid the same per hour if you're on a salary. The one drawback of salary is that doctors put on salary tend to work less hard because they're already paid up front, and why should they bust their ass? The second way of doing this would be a fee-for-time system, where you translate every procedure into a unit of time. For surgical procedures, you do it based on OR time booked for that procedure. For primary care, you could schedule a 10-minute visit, a half-hour visit, a 45-minute visit, and you know the patient, you know which ones are going to be simple or complicated, so you book the appropriate amount of time for that patient. This is what we had in psychiatry up until a couple of years ago when they put us on E&M codes, and now we're in the same boat as the rest of you. But a fee-for-time system is basically incentive neutral. You're paid the same regardless of what you're doing. And the fee per hour should be adjusted based on the training and the overhead required to practice your specialty. But you should be paid the same regardless of what you do so that you can focus on what's best for the patient instead of trying to game the payment system. The third way to do it would be to capitate your practice. And I'm not talking about capitation for the total cost of care like they tried to do to primary care doctors in the HMO era. I'm talking about capitating just for what you do. And my inspiration for this idea came from the direct primary care model, which is spreading all over the mainland, and particularly in areas where there's a high rate of uninsurance. Some of these doctors decided they weren't going to deal with insurance at all. They were going to take no insurance money, and they were going to just bill the patient for their services as a monthly capitated fee. So they said, okay, if I don't have to deal with insurance, all I need is myself and a medical assistant to run a primary care practice. I don't need billers, coders, pay for documentation, pay for performance, any of that. It all drops out. You agree with your patient that you're going to pay a monthly fee and I'll take care of all of your primary care needs. For a panel of $1,000, in order for 1,000 patients, in order for the doctor to make $300,000 a year, they needed to charge each patient $40 a month. That's it for comprehensive primary care. So instead of charging the patient, have the health plan, like HMSA, pay the $40 a month for the comprehensive primary care, and that eliminates all the complications of billing, coding, ICD-10, all that stuff disappears, and you can just focus on what's best for your patient. And some patients are going to require a lot of time, some are going to require a little time, but it averages out over your population. This would be far, far easier to deal with for doctors. If we did this, the doctors doing direct primary care on the mainland also have much lower rates of preventable hospitalization than doctors in traditional practices because you're not tied to the visit to get paid. You're already paid for taking care of the patients. If someone has a simple problem, you can deal with it on the phone, and you don't have to worry about calling them into the office because you won't get paid otherwise. If they have something complex, you can devote as much time as needed to address all their problems in one visit instead of saying, I only have 10 minutes with you, I can only deal with one problem today. If it really does bring down the rate of hospitalization, the hospitals are going to lose money. So then what you do is you simplify administration for the hospitals too. You pool the money from Medicare, Medicaid, and commercial insurance, and you pay the hospital a flat global budget for their operating expenses to deal with that patient population. Then they don't have to do billing, coding, etc. That brings their administrative costs down by about 15%. You can take that off the top in what you pay the hospital and leave them intact, able to care for their patients with much lower administrative overhead. So the three-point summary of how to achieve more cost-effective care, how to achieve the triple aims is first, you assure care for everyone in the most cost-effective, generally outpatient settings, so that you try to eliminate the access problems. You simplify and streamline administration, and you use administrative savings, not reductions or restrictions in care, to bring down the prices paid for health care. If we did this, we would be doing what all the other industrialized countries in the world do, and that's why they spend so much less than we do. If everyone had the same comprehensive coverage, and if it were administratively simple to practice any specialty in any location, and if physician pay were equitable based on training plus practice costs, and if physician pay were not skewed toward procedures or by pay for documentation and pay for performance incentives, then many more physicians would choose primary care and specialties like psychiatry again. Patients would have access to care based on their medical needs, and U.S. healthcare spending would come in line with other industrialized countries. Thank you very much.
I think we have time for some questions, and Dr. Kemble will repeat the question from the floor. Dr. Ng.
Dr. Kemble, I appreciated your analysis. I would say that there are certainly possibilities that something like that model could work. However, I would other countries that we keep trying to compare our country with include two factors that were not mentioned. One is control of drug costs. In all these other universal health, the government has the privilege to get a bid from the pharmaceutical company, which will lower the cost on a bidding competitive process. Now,
You're absolutely
it's
right.
against the law in the United States.
You're absolutely
All
right.
right, number two, they do not have to worry about what we call overuse of tort. In other words, we have a medical malpractice system in our country that incentivizes suit. In anybody's poor outcome, this is exactly what our trial lawyers want. Now, in our country, it is promoted, and it certainly adds a lot of cost to the cost of care, and not just by the suits, by the procedures that doctors have to order in the emergency room. Now, I speak from experience, because I had a daughter who went to an emergency room here in this community with a minor brow injury, which I sewed up myself, took care of her. And on the way out, the triage nurse said, well, now she has to be seen by our triage doctor. I said, fine. So I left the room, I came back, and he said to me, well, we're going to send her for our CT. I said, what? Why? Now, I don't know what was his incentive, whether it was practicing preventive, lawsuit mentality, or maybe a much more cynical point of view, he raises the fees that are accepted by the hospital. Whatever it is, that has to go, because if you don't have addressed the medical lawsuit practice community and the climate here, in Europe they don't do this. In Canada they don't do this. Their cost of medical malpractice is minimal.
Right. You're absolutely right.
Those two factors have to be included in your plan.
Yeah, you're absolutely right, and I would include both in the plan. If you had a universal system, you could take health care out of medical malpractice, workers' comp, auto insurance, put it in the universal system, and you can litigate, negligent behavior or lost wages or things like that, but take health care out of it, put it in the universal system, and you could save at least 2/3 of the cost of medical malpractice right there. And you're absolutely right that our current system forces people to sue, because if you're in an accident, your regular health insurance plan will say, we're not responsible, and if you want your health care, you have to sue to get it. So we really, both the size of judgments and the frequency of claims would go way down if you had a universal system that included health care and take it out of injury litigation. And you're also right about the drugs. That's an absolutely essential component, and I would want to include that.
One more public question.
Oh, I want to say one more thing. In Hawaii, HMSA has about a 70% market share. And if they were to do what Western Colorado did, we could do 70% of this right here on a private basis without needing an act of Congress to do it. And that's what I would like to see happen here in Hawaii.